Thank you. Good early afternoon. So as Sham said, I'm Nicole Zavagnin. I'm the Regional Primary Care Lead in the Northwest for Cancer Care Ontario, which roughly means that I'm responsible for supporting all of you with respect to any new information, education, or support as it relates to cancer screening programs, and also feedback, the vital context and information to the CCO programs as they're being developed as it relates to the northern context. So we'll get started. I first want to start just with a land acknowledgement, certainly acknowledging that where I work and live, the city of Thunder Bay is located on the traditional lands of the Anishinaabe, specifically the Fort William First Nation, which is part of the Robinson Superior Treaty of 1850. I also recognize the Métis people and their historical and ongoing connection to this land. I honor and respect the diverse Indigenous communities who have cared for this land for generations and recognize their enduring relationship with the environment. These words require action to follow, and I am committed to the ongoing process of reconciliation and building relationships with Indigenous peoples based on respect, understanding, and trust. So as we walk through today's presentation, I will ask I will address all questions that you have at the end. There should be a good amount of time to go over any questions or feedback that you have with respect to the OLSP program, or even questions around cancer screening more generally. If you, like me, have difficulty holding questions in your mind for that long, feel free to pop them into the chat, and then we'll certainly address them towards the end of the presentation, just to be sure that we're not covering it already. So as I mentioned, I'm Nicole Zavagnin, a family physician in Thunder Bay, and for over a decade have again been the regional primary care lead for CCO. And today we're going to talk about the newly launched Ontario Lung Screening Program within the Northwest, which is lung cancer screening for people at high risk. In terms of relationship with financial sponsors, I don't have any to disclose aside from being the regional primary care lead with Cancer Care Ontario. So again, no other financial support other than my regional lead position, and that would be my only conflict of interest as well. So again, just in terms of bias, so the presentation that I'm bringing you today is accredited and is compiled through the central sort of education hub at CCO. And so these are not the opinions of myself, but the evidence-based information as compiled from Ontario Health Cancer Care Ontario. So the learning objectives, so we're going to go over the evidence for screening people at high risk and apply it to the Ontario context, analyze the benefits and harms of lung cancer screening, outline the steps in the screening pathway for the OLSP, because there are some key differences compared to the screening programs, the cervical screening, breast screening, colorectal screening programs that we're all very used to at this point. And just go over again how we identify people who should and should not be referred for lung cancer screening through the OLSP. So again, we'll walk through just a bit about the burden of lung cancer and evidence supporting screening, talk about screening people at high risk of getting lung cancer, what the referral process looks like, how we undergo informed participation and the component of smoking cessation counseling, what low-dose CT is completed, follow-up, recall, and communication of results, and then just some tips for talking to patients about screening and other issues. So certainly when we look at any organized screening program, some of the requirements are that this is a condition that has a significant burden, and that there are investigations that can be done that can identify either at an early stage of cancer development or in a pre-cancer stage, as we see with Ontario Cervical Screening Program. Now we've even gone a step back with OCSP to be able to identify persistence of HPV, which is a risk factor for precancerous cell development. So again, the earlier we can intervene, the more ideal. And of course, we have to balance the risks, benefits, and sensitivity and specificity of those tests. So when we look at the burden of lung cancer in Ontario, so in 2022, lung cancer was expected to be the leading cause of cancer death for people in Ontario. And in 2022 was projected to account for approximately 22% of all cancer deaths, about 7,000 for that year. And lung cancer, unfortunately, is usually diagnosed at stage 4, which has a 46.7% of all lung cancer cases, and has less effective treatments. So the 5-year survival for a stage 4 malignancy is about 5.4%. So again, when we look at a good screening program, it helps us identify something early when treatment has a better chance of working. So when we look at our region, particularly when we consider our First Nations individuals, the prevalence of non-commercial tobacco smoking among First Nations people is actually nearly 2 times that of non-Indigenous populations. And lung cancer is the most commonly diagnosed cancer and leading cause of cancer death in First Nations people when we look at the period from 1991 to 2010. And most recent evidence suggests that that trend really hasn't changed much. Lung cancer incidence and mortality are significantly higher for First Nations males and females than for non-First Nations people living in Ontario. So again, when we compare survival, even when we compare similar stages, First Nations males unfortunately have a significantly worse survival after their lung cancer diagnosis than non-Indigenous individuals. So we look at the lung cancer incidence and we reflect it a little bit more locally. So of course we know what the Ontario rates look like, but when we look at the Northwest specifically, you'll see that we're the second bar following just behind the Northeast. So the second highest lung cancer incidence from 2016 to 2020 in Ontario at 84.3. When we look at risk factors, I'm sure many of you are nodding your heads as I say all of this, but when we look at the risk factors, number 1 risk factor being smoking, again, we're just behind the Northeast with the second highest rate of smoking per 100,000 in Ontario. When we look at mortality rate, unfortunately, that trend continues. So again, across Ontario, we have the second highest lung cancer mortality rate for the period of 2016 to 2020. As I mentioned earlier, of course, the later stage of diagnosis, the lower the survival rate or worse the prognosis is for the individual who's diagnosed. And we can see that a significant proportion, both from Thunder Bay and adjacent locales, and particularly for our regional folks, certainly the majority of our malignancies are diagnosed after stage 3A, where mortality significantly increases. So if we look at 5-year survival at stage 1, it's about 67.7%. When we get to stage 4, that's dropped again to about 5.4%. So many of you maybe have heard that in some jurisdictions, lung cancer screening has been happening for a few years now. And so CCO first launched a pilot and then went live with some hub sites, and we'll talk about that in just a few moments, and have been studying essentially the outcomes of that screening in the Ontario population since launch. And so we'll talk a little bit about what it means to screen people at high risk of getting lung cancer within Ontario specifically. So anyone who's familiar with the with our cancer screening programs would have, some understanding certainly of what the benefits of organized cancer screening programs are. So certainly they're run centrally using consistent policies and processes, and a lot of time and effort goes into evaluating scientific evidence to determine appropriate cancer screening guidelines, meaning whom to screen, how frequently should they be screened, when should they be rescreened, and what findings are at elevated risk to warrant further investigation and management. And throughout the implementation and sort of ongoing, there's tracking and measurement of performance and quality metrics. Opportunistic screening, so certainly I know since some jurisdictions in Ontario have had lung cancer screening for a while, people have been offering some opportunistic screening, which is just sort of ad hoc. It's occurring outside of an organized program. And some of the challenges with that is we're never sure exactly who meets criteria, who should be screened, how frequently should they be screened, what's the best test to use for them. And when we get findings back, which ones are actionable, which ones might not be, and what do we do after that initial screen? How frequently do we follow it up? So some of the challenges that we see with opportunistic screening. So certainly some of the potential harms when we screen outside an organized program is that they may not get the most evidence-based screening tools. So some people may mistakenly get a diagnostic CT scan, which exposes them to significantly more radiation than the low-dose CT. So low-dose CT is about less than 1.5 millisieverts, which is about 1/4, 4 times less than that of a traditional CT, or about equivalent to about 15 chest x-rays in 1 year. It's a single breath hold and takes only 5 minutes and is a non-contrast study and is basically looking at the difference between air and nodules. People may also have unnecessary follow-up testing. Like I said, when we don't have any guidelines to guide us, we often make our own rules or try and find some evidence which may not apply specifically to our population or to our patient. And then we may be ordering unnecessary follow-up testing or unnecessary diagnostic procedures, which can be quite invasive. Oh. So when we look at the potential benefits of organized screening, is certainly the #1 aim is to identify lung cancer at an early stage when treatment has a better chance of working. Again, screening with low-dose CT scan has been shown to reduce the chance of dying from lung cancer. And as well, the organized cancer screening program through the OLSP provides you with those pieces that are very helpful for guiding our patient through the system, such as standardized reporting of results and follow-up recommendations for lung nodules, which helps us to reduce false positives and any associated harms. Also, as part of the OLSP, which you'll see in a few moments, there's direct access to smoking cessation services and resources, and as well a very smooth transition through for lung diagnostic assessment if that's found to be necessary based on their screening results. Again, there are certainly some potential harms of any investigation or intervention. So certainly low-dose CT scan does give off a small amount of radiation. As I noted before, it's about 4 times less than the traditional CT, equivalent to about 15 chest x-rays. Again, a small chance that extra radiation from many low-dose CT scans over time could increase risk of malignancy. False positive results, as I'm sure we all see with any investigation, can cause stress and anxiety and lead to unnecessary diagnostic assessments with the risk of complications. So bronchoscopy, biopsy, thoracotomy, thoracoscopy all have risks associated with those procedures. And then, of course, screening may lead to overdiagnosis, meaning we've identified a cancer that may not have caused harm to that individual had they not been screened. So lung cancer risk prediction models. So essentially, one of the ways of trying to mitigate some of these potential risks is by utilizing a risk prediction model. So the aims of that is really to try and minimize overdiagnosis by accurately selecting high-risk individuals for screening. So lung cancer risk prediction models are more sensitive in identifying individuals subsequently diagnosed with lung cancer in comparison to categorical criteria. So again, just what's the patient's age and what is their PAC year, and then deciding screening based simply on that and not evaluating any other risk factors that may increase or decrease their risk for the development of lung cancer. So again, the additional benefits of utilizing a risk prediction model include higher positive predictive value, greater life years gained, lower number needed to screen to avert one death or mortality, and they are more cost effective when we're looking at applying these tests to a population. So the Ontario Lung Screening Program, as I mentioned before, really as a pilot was launched in June 2017 to best assess how to implement organized lung cancer screening for people at high risk across Ontario. So data and evidence was utilized from programs across the world who were performing lung cancer screening. And then we wanted to see how best to model this and implement this with our Ontario population. The pilot transitioned formally into the Ontario Lung Screening Program in April of 2021. And the OLSP hub sites were level 1 or 2, initially level 1 thoracic surgery center hospitals with on-site organized programs for lung diagnostic assessment. And so some people ask, well, why didn't we have one right away? Certainly when you look at some of that data around our risk factors and the morbidity and mortality surrounding lung cancer in our region, it really has mostly to do with the level of thoracic surgery center that we are. And so some time to kind of launch that and iron out the kinks in some of the highest level major centers, and then operationalize and launch lung cancer screening more broadly across the province. So a lot of work has gone into getting Thunder Bay ready to launch as a hub site. And as we'll discuss, so initially will be sort of a hub model where screening will take place in Thunder Bay proper. And then over the coming couple of years, we'll be increasing the capacity of the spoke sites in terms of supporting screening in a more regional basis. So these were the current OLSP sites. So again, I've mentioned that the program is a little bit different than what we're used to with respect to the organized screening program. So for Ontario breast screening, Ontario cervical screening, and Ontario colorectal screening, you sort of do the criteria assessment in your own clinical setting, or the patient is assessed by whomever is completing the requisition or referral form, and then they go directly into screening. There is a key difference, as we talked about. One of the ways to more effectively manage risk and positive and negative predictive value and decrease harms potentially associated with screening is to include a risk assessment. So the way individuals will flow through the OLSP is that there will be the sort of recruitment stage, which is where individuals either will self-identify in the community or will be identified by a care provider. Then they will flow through, so the initial referral brings you through to a risk assessment. We'll talk through all of this in a minute. And then their eligibility for screening will be based on the risk prediction model. So again, when we're initially referring the individual, we're referring them not direct to screening, but for risk assessment. So that's going to be a really key piece to communicate to the patient, is that just because we've done the referral through doesn't mean that now a low-dose CT is directly booked. It means you'll have an initial assessment to evaluate risk of development of lung cancer, and then the decision of whether to proceed to screening or return to usual care. As a part of the program, there is dedicated smoking cessation offered to all individuals who currently or within the last 30 days have smoked. Ongoing quality assurance and standardization from a radiology standpoint. And then, of course, if an individual is found to have a positive scan, they will seamlessly transition into the lung diagnostic assessment program. So again, clinician, physician, or nurse practitioner completes and submits the screening referral form. Again, not everyone who meets referral criteria will be eligible for screening. So when an individual meets criteria to be able to be referred for assessment, you fill the form and send it in. Then a risk assessment will happen, and their eligibility for screening will be determined by a risk prediction model. And smoking cessation services at that stage are offered to all people who currently smoke. And then those who are eligible for screening will proceed with their screening visit. And again, at multiple stages, we'll have discussion of benefits, harms, and limitation of screening, and will be offered smoking cessation supports at every visit. So this is sort of the overview of the flow through. So very similar to how we have very clear guidelines for thyroid and breast through the BI-RADS and TI-RADS, we have lung-RADS scores. And so depending on the information communicated on the radiology report, a lung-RADS score will be assigned, and then the follow-up will flow dependent on what that lung-RADS score was. Individuals who are brought into the program will automatically flow through for any follow-up without requirement of re-referral. So they'll stay within the program. And we'll talk in just a few minutes about the potential for incidental findings and what happens with those. So again, just to clarify the referral process. So again, eligibility for screening is sort of a two-step process. So the part that's most relevant for those who are on the webinar today is, who do I refer for risk assessment? So providers will refer people who meet risk triage criteria. So that's going to be any individual age 55 to 80 who have smoked cigarettes daily for at least 20 years. I want to clarify that that's not a 20-pack year history. That's any daily cigarette smoking for at least 20 years, and they do not have to be consecutive years of smoking. So if they've smoked 5 years, half a pack a day, and then another 10 years, and then quit, and then another 7 years, that's cumulative over 20 years of smoking, and the total quantity of cigarettes daily is not taken into account. So again, it's not 20-pack years, it's just smoking cigarettes daily for at least 20 years in total. And again, individuals can self-present to the OLSP site to have their age and smoking criteria assessed. However, they will not be able to have the scan if they are approved and found not approved, if they're found to be eligible for screening. That will require sign-off from a provider. And I'll talk to you about how that flow happens. And then again, step 2, if they meet that criteria of 55 to 80 and smoking cigarettes daily for at least 20 years, they flow through to step 2, which is their risk assessment. And the OLSP site will conduct a risk assessment with anyone who meets criteria. So we have the individual who will be conducting those, I believe, on the line today. So if you have any questions for her, we can direct those at the end. And then as well, the results of the risk assessment determine whether or not the individual is eligible to get screened through the OLSP. I just want to say that individuals who are over 80 can be referred after a detailed discussion with their primary care provider about their overall health status, the difference for those individuals would be that they wouldn't just automatically be recalled as individuals in the 55 to 80 group. They would need a new referral annually if they were to continue on, say, 81 to 82, 83, 84, etc. Some people ask, well, what about my patient who's smoked for 17 years? So certainly they've cast a fairly wide net with the inclusion criteria to have a high sensitivity. So it is possible, but by the data, very unlikely for someone who smoked less than 20 years to then meet the risk criteria to be eligible for screening. And again, you'll have to reassess then that patient when their smoking history does hit that kind of threshold of 20 years. So again, not everyone who meets the referral inclusion criteria, so 55 to 80 with the 20-year smoking history, will be eligible for screening. It's important to make sure to communicate to the patient they may not be eligible upon the risk assessment. In the first years of the pilot, over 66% of people who completed the risk assessment were found to be eligible for lung cancer screening. We'll talk a bit again later, but one of the key pieces is that the threshold is 2% for the risk assessment. So anyone with a risk of 2% or greater. And so really we can reassure our patients that if they weren't eligible for screening through the OLSP, it's because by a risk prediction model, their risk of development of lung cancer over the next kind of 5 to 6 years is less than 2%. So that's good news for them, because I know it's going to be a struggle, certainly for some patients who are very concerned if they don't meet inclusion criteria. So again, this is a screening program, just like with any other screening program. People should not be referred for diagnostic assessment. So if we have somebody with a diagnosis of lung cancer, if they're undergoing surveillance for suspicious lung nodules already, if they have features that are highly suggestive of a lung malignancy, like ongoing hemoptysis and with unexplained weight loss, or they're currently a part of the diagnostic screening program already. These are individuals who are needing diagnostic investigations and wouldn't be eligible for lung cancer screening. So the OLSP referral form, I'm sure none of you can make that out very well, but it has been distributed broadly. And if you don't have it yet, please just let Sham or myself know at the end of this call, and we'll make sure that it's brought to your facility. But the OLSP form essentially authorizes several activities. So similar to sending a patient through in the OBSP program, when you send your patient for that risk assessment, you've already pre-authorized that if they are found eligible for screening, that they will then be directed through to the low-dose CT scan for baseline screening, and then ongoing routine annual screening and follow-up of their lung nodules according to the BI-RADS score and the program guidance. And then as well, if indicated by whatever finding, they need a referral through to the lung diagnostic program, that automatically happens after you've sent that initial referral form. So you will get communication back, but you don't have to send anything additional after the first OLSP referral form. Okay. The other piece is that by submitting that form, we're technically the ordering provider. And so certainly we are responsible for ensuring follow-up of any incidental findings. The OLSP has been working very hard to ensure that there's very clear directions of what to do with any incidental findings that might come about. So again, individuals who undergo the assessment essentially are asked about their age, education, smoking history, BMI, any history of COPD, personal history of lung cancer, and family history of lung cancer. So some things you may want to give your patient the information about before or at the time of referral, just so that they know the answers to those questions. And the reason for this is that studies have shown clear increased risk with increasing patient age, current smoking status versus former smoking, increasing smoking intensity, so how many cigarettes are smoked per day, increasing smoking duration, history of COPD versus not, any personal history of cancer, and any family history of lung cancer. And interestingly, their lung cancer risk decreases with level of education, increasing quit time, so the longer it's been since they quit smoking if they have, and increasing body mass index. So again, the outcome of the risk assessment is a risk score that represents the probability of developing lung cancer in the next 6 years, as I've mentioned. And people are eligible for screening if they have a risk score of 2% or greater. So again, if the patient is not found to be at high risk, which is again over 2%, then they will be referred back to primary care provider with that information. And you can assure your patient that it was found that their risk over the next 6 years of development of lung cancer was less than that 2%. And then of course, reassessment can be ongoing if they continue to smoke, or if their risk factors change in any other way, they can be re-referred for a new assessment. So again, provider referral, so you complete the OLSP referral form. and the OLSP site confirms the person meets age criteria and then is booked for the initial risk assessment, which is conducted by phone. And then if the individual is eligible and chooses to participate, they flow directly through to Lodo CT. Now, if your patient has self-presented to the OLSP site without a referral first, which they are able to do, again, the same process will happen. So initially, they will be confirmed that they meet age and smoking history. They will have their risk assessment completed if they do. And then if they are found to be eligible to participate and they have a primary care provider, the OLSP site will contact you and say, hey, your patient has self-referred to the OLSP. They've been found to meet criteria to be eligible for lung cancer screening. Will you please send the form so that we can proceed with the screening test? And there will be and is a process for supporting unattached patients to ensure that they can obtain screening as well. So again, currently we're looking at a broader program to support all unattached patients in the screening program, but there may be reach out from the regional cancer programs, and if anyone is interested in supporting any unattached patients, please let us know. And again, hopefully we can support those patients in both their cancer screening and then any management of incidental findings. So we'll do a few case studies. So if we look at Jane, who's a 52-year-old individual, Jane has smoked cigarettes every day from 18 to 38 and has not smoked for the last 14 years. And people can just pop a yes or no in the chat. Can Jane be referred to the OLSP? No, I'm going to go based on, there we go. We got a couple of answers. There we go. We're getting all no's. That's correct. And the reason is, though Jane meets the criteria for years smoked, Jane is 52. So Jane does not yet meet inclusion criteria for risk assessment, as individuals need to be within the age of 55 to 80. So again, if at 55 Jane would like to be referred, then at that time likely will meet criteria. So then we have Dwayne. Dwayne's a 65-year-old. Dwayne has smoked cigarettes from age 19 to 33, has quit smoking for 15 years, and then started smoking again at age 48 and currently smokes. Is Dwayne eligible for lung cancer screening? Is 65 and has smoked for about 14 years. Yeah. Yes. Excellent. So yes, Dwayne meets both age and smoking criteria. He can be referred, and then he will have his risk assessment to determine if he's eligible for screening. Okay, so informed participation in smoking cessation counseling. So certainly at the time of the, look happy here. At the time of the telephone risk assessment, I'm just trying to get this chat out of my way. The OLSP provides a brief overview of potential benefits and harms of lung cancer screening. And again, before the first visit, OLSP will provide access to an information sheet that talks about lung cancer signs and symptoms, the low-dose CT scan, possible results and next steps, benefits, harms, and limitations of screening, and again, offering smoking cessation. So very well informed at each step before proceeding with participation in the program. And as well, smoking cessation, as I mentioned earlier, offered to all individuals who currently or within the last 30 days have smoked cigarettes and have engaged in any way with the OLSP. So people who are eligible for screening will be offered a smoking cessation counseling session at the OLSP site with a trained counselor. And individuals who are ineligible will be offered a referral to Health 811 to support smoking cessation, or individuals can also access Health 811 themselves or visit the Smokers Helpline. We do also have some specific supports for our Indigenous population. One is Talk Tobacco, which is a free confidential program, which offers culturally appropriate support and information about quitting smoking, vaping, and commercial tobacco use for First Nation, Inuit, Métis, and urban Indigenous communities. It's available by phone, text, live chat, or online community support groups. And they can register for free trial packs of Nicoderm or Nicorette gum. And of course, as a part of the Indigenous Cancer Care Unit at Ontario Health, their Indigenous tobacco program works with First Nation, Inuit, Métis, and urban Indigenous and non-Indigenous partners to reduce and prevent commercial tobacco addiction, and really focuses on frontline supports, partnership development, program performance, smoke-free bylaws, and other policies. And there's the link there to check out TobaccoWise. So follow-up, recall, and communication of results. So what happens to your patient once they're in the program? So again, as we've mentioned, low-dose CT uses much less radiation than diagnostic CT and does not require contrast. So individuals who have kidney disease need not worry that this is a non-contrast study. Participants will get their screening results and next steps within 2 weeks of their scan. So we can reassure patients if they're waiting for results that they should be available to them within 2 weeks. And the standardized lung cancer screening radiology reports will include 2 things. So it'll include their screening results. So any nodules that are identified will be categorized for size, characteristics, and then assign the Lung-RADS score. And then next step for screening will be based on that Lung-RADS score. And then the second component would be any incidental findings. So abnormalities unrelated to lung cancer seen on low-dose CT scan, things that we've all seen on reports like coronary artery calcification, aortic aneurysm, osteoporosis. So again, the Lung-RADS, American College of Radiology, Lung-RADS is a quality assurance tool, which again helps really to ensure that we're getting standardized reporting and management recommendations that are consistent. Because again, I know a lot of us have had challenges where different things, we're told different recommendations for management or follow-up. And so this really seeks to standardize that, reduces confusion in screening CT interpretations, and facilitate outcome monitoring. So again, since the launch, they have been using Lung-RADS to inform next steps for lung cancer screening. So again, this just goes through what will be recommended. Now, this will all be on the report, so no need to screenshot unless you want to have it, and we'll make access to the slides available to all of you as well. But depending on their Lung-RADS score, you can see escalating sort of follow-up. So in most settings, there'll be negative or, benign appearance or likely benign, and that would be follow-up between 6 to 12 months. And then as we go up in terms of the Lung-RADS score, the indication for rescreen or referral for a lung assessment. And if you see, so if we look at, say, Lung-RADS 1 or 2, the probability of lung nodule malignancy is less than 1% in Lung-RADS 1 or 2. It's about 1 to 2% for Lung-RADS 3. 4A goes to about 5 to 15%, hence the earlier screening interval. And then 4B is greater than 15%, again, so a shortened interval for follow-up. And then 4X is escalated to above 15%, and then those individuals will flow through to the diagnostic assessment program. So again, the radiology report, you can't see that, but that's okay. Again, it really will just include everything I've talked about. So any findings related to lung cancer screening specifically, so any lung nodules and the Lung-RADS score, and then the next steps. And again, patients will automatically be recalled for those follow-up scans once they are in the program. So you won't need to be ordering a 3 or 6 month follow-up scan. That will be automatically done. You don't have to fill anything different for them to go through to the diagnostic program. That will automatically happen. And then as well, so at the bottom of the report is where the Lung-RADS score, actionable incidental findings, and next steps will be. And we're going to talk about the incidental findings in a little bit, so don't worry, I haven't forgotten. So communication to primary care, when are you going to expect communication from OLSP? So once you've done the referral, or again, if you haven't referred the patient, but they've come through and are found to be eligible, after their risk assessment, you would get information sent to you to inform whether or not they're eligible for screening. And if they've self-presented and are eligible, you'll be asked to fill the form so that they can proceed with their screening. At the time of their low-dose CT scan, you'll receive the radiology report and any and what the next steps are going to be. And then as well, if your patient has required a referral to the lung diagnostic assessment program, you will receive information about that. And then of course, if they go through to diagnosis and treatment, all information will flow through from the lung diagnostic program or any treating providers. So the actionable incidental findings. So incidental findings means anything beyond the target finding of a lung nodule. So that can be in the lung parenchyma, but often in the surrounding anatomy that's captured on the CT scan. So what's the implications? Well, it's often unknown by the radiologist without any additional clinical information. Maybe it's something that's clinically irrelevant. Maybe it's relevant but known to you already. Or maybe it's something that's undergoing investigations, or maybe it's something that's relevant that you haven't heard about yet. Actionable findings, if you didn't already know, require follow-up or further investigation, depending on what they are. And so the most common actionable findings over the initial study period of OLSP and the few years that it's been launched were indeterminate renal nodules or masses, hepatic nodules or masses, emphysema, breast nodules or asymmetry, coronary artery calcification, and thyroid nodules. Everybody's probably nodding like, yeah, that's what we expected. So the way things will be presented on your radiology report will be very clearly outlined for you in terms of what is and is not an actionable finding. So it'll be listed as incidental findings in its own separate category, and will be separated into not actionable and actionable. And so things that, for example, would be non-actionable would be, hey, we saw some simple renal cysts and nodules that are too small to characterize, or some fatty nodules without calcification. So those don't require any further evaluation, regardless of the clinical setting. Nothing actionable here. And things that are actionable, so any other lesions, and that defers to the judgment of the reading radiologist, and they'll give you a clear recommendation. So that should be your expectation on these reports, is that there is recommendation for what to do. And again, if you've already investigated this incidental finding and that's already been worked up, you don't need to restart that process unless this is a new or uninvestigated finding. So again, the recommendation will talk to you ultrasound or additional imaging. Now, if it's something you've known about and maybe haven't done what the recommendation is, that would be something to consider at that time. Again, it's all going to be clinically dependent on the context. So I think we're getting close to time. So this just has a